Welcome back. Let's Get Physical Therapy is an educational podcast brought to you by MedStar Health and hosted by me, physical therapist Becca Schumer. I will be sharing the mic with tons of healthcare professionals with the goal of educating and inspiring fellow PTs and future PTs. We hope you find this both informative and inspirational, ultimately optimizing how we treat our patients and grow as professionals. Please enjoy today's episode. Today on the podcast, I am very excited to host Dr. Jen Harris, who is an anesthesiologist for MedStar Health, primarily working out of MedStar Health Harbor Hospital. I selfishly am very interested in this topic, but I also think it's important for us as PTs to understand what our patients go through when they go through a surgery. So I kind of let her do her own bio. I'm going to let her introduce herself, and we're just going to hop right in. Good morning, Dr. Harris. How's it going?
Good. How are you?
I am doing well. I'm really excited to have you today to talk about anesthesia. I am super curious about this topic, so I'm selfishly bringing you on to talk all things anesthesia today.
All right. Well, let's see what we can cover.
I love it. We have a lot to cover, but let's see what we can get into. Before we do that, I would love to hear your story. How did you become a doctor? What was your journey to get there?
It's a really long story, so I will abbreviate it. I never intended on going into medicine. I was actually a marine biologist. I'm from Canada originally, so I was working for the Department of Fisheries and Oceans, doing contract work for the government. And I just didn't like the uncertainty around employment and the lack of funding for the research. And I just was looking for a different career that would provide me just more like financial and life stability and security. So I decided to go to medical school, and I went to the Caribbean. And I knew after starting medical school that I didn't want to do primary care. I wanted to do a specialty. And I thought I wanted to be a surgeon. And then I slowly realized that many surgeons are not happy. And I think it's because they have very poor work life balance. And so when I was discovering this, I was trying to figure out what would provide me with good work life balance, but also get me doing something that I loved. And that's when I found anesthesia. And so I stumbled across it probably in my fourth year of medical school. So I had to quickly take up some electives and see, is this really what I wanted to do? And then I applied for and matched into residency. And here we are.
That's a good question in itself. What is the journey of becoming an anesthesiologist? Like, what's the schooling? How many years? Is there a fellowship? What is the process of that?
So, yes, you typically have a 4-year undergrad before you, 4 or 5 or whatever your undergrad is, but you have a degree, an undergraduate degree, before going to medical school. In North America, at least medical school is 4 years. So in some European countries, you can just go directly from high school into medical school and it's a 6-year degree. But here in North America, it's 4 years undergrad, 4 years med school. Then you apply for residency. So for anesthesia, you have to do a intern year, and that can be in medicine or surgery. So you do 1 year of generalized either medicine or surgery, just to kind of, I guess, get your feet wet. And then you do 3 years of anesthesia training, specialized anesthesia training. So you have 4 years of residency to complete before you're general anesthesiologist. And then you can do a fellowship, which most fellowships are 1 year. And there's many different fellowships you can do. So there's pediatric anesthesia, there's cardiothoracic anesthesia, there's chronic pain management, there's regional anesthesia, which is up and coming. And I think in the last probably 5 years, it's really grown. So it's really popular. There's a few other specialty ones that you can do, but they're just not accredited yet by the ABA, which is the American Board of Anesthesiology. So those are just the few on the top of my head that I know of.
Okay, very interesting. Didn't know that.
Yeah.
And what's a typical day for you? What's a typical day of an anesthesiologist working in ortho?
Okay, so I think there's any disclaimer. There's no typical day in anesthesia because every day is different. And that's what makes our job kind of exciting. I mean, I guess you would have a typical day if you were working at an outpatient surgery center. You would probably go in, start around 7, maybe finish around 3, 4, maybe 5, depending on the day. And then that would be a typical day. For me, where I work in a hospital and I take call, it's very different. So every day is different. So For example, yesterday I was home in the morning, then I went to work at 3 p.m. and I took over the operating rooms that were still running and any surgeries that needed to be done, which included 2 broken hips that we had to do. And then I worked overnight. So I cover OB overnight. So ladies who come in labor, who need epidurals, C-sections, any obstetric management, I'm there for. In our hospital, because it's a small community hospital, there's no intensivist overnight. So we have a small ICU, but there's no ICU doctor who's the intensivist. They're not in house. So if there's any problem in the ICU or they need a patient intubated, I get called. If the ER has a problem or a difficult airway, they're calling me. So it's kind of just me getting called, quite regularly overnight. And then I finished my shift, I guess you would say, at 7 o'clock this morning. So that's a call evening. A day would be I go in at 7 a.m. Typically, you see your patients in pre op before surgery. You have to see them, consent them, make sure that they're safe and able to have surgery that day. Usually the ORs are starting around 7:30, so we want to try to get our patients into the operating room on time, because if we fall behind, then it just is a cascade effect throughout the day, and puts everything else behind. And then it's just running the ORs, seeing patients, making things move smoothly, dealing with any emergencies that come up, that kind of stuff. Typically, a day at the hospital is 8 to 10 hours if you're not working overnight or on the weekend.
This is a question I didn't prep you for, but I'm sure you're the answer to it.
Yeah.
Why is it if you have surgery at 7 a.m. or 7 p.m., you have to be NPO? What is the deal with that? Why is it so important that we cannot eat after midnight?
So it's not necessarily midnight. There's no special
They always say
like
midnight.
I know they say midnight because people aren't good at following directions. So ultimately we want patients to be NPO, because if they have stuff in their stomach, then they're at higher risk for aspiration when we put them to sleep. So when you go to sleep, all your muscles get relaxed, which includes your sphincter to your stomach. So if there's anything in there, it's going to come back up, and then you risk aspirating it, because when you're asleep, you might not be able to protect your airway, which can lead to aspiration pneumonitis, aspiration pneumonia, sepsis, and really bad outcomes. So typically we say clear liquids 2 hours. So you can have water 2 hours before surgery, and that's fine. You can have apple juice, clear apple juice 2 hours before surgery. Do not drink orange juice with pulp. That's not clear. You can't drink that. And anything obviously with protein and fat is going to take longer to digest in your stomach. And so usually we say that's like a light to heavy meal, which is going to be 6 to 8 hours. So those are kind of our cutoffs just for safety. But because people are usually having surgery at 7 a.m., 8 a.m., we kind of just use midnight as our cutoff. And if you're having surgery at 4 p.m., well, sucks to be you, because you're going to be like 18 hours NPO.
I have a funny story. The last time I had surgery, the gentleman next to me, they asked him, "When's the last time you eat?" Because they asked you that, and he admitted that he had a BlackBerry like 2 hours before, because he was feeding his daughter and she wasn't eating, and he was trying to get her to eat it, so he ate it. Then the next person comes in and asks the same question. He tells the same story, and the next person comes in. He's like, "No, I haven't had anything." I think he realized that
Yeah.
maybe he shouldn't have had anything. It was pretty funny, but.
Yeah, but then it's also communication, right? So
Mhm,
then
mhm.
like, oh man, he ate blackberries.
A BlackBerry.
He only had one, but then the
Yeah.
story gets, as the story gets relayed through nursing staff, through providers, through, physicians, by the time it comes to me, it's like, well, he ate a fruit salad at 6 a.m. Like, what? So that's another reason why, like, people are going to ask you the same question 20 times, because we want to hear it for ourselves from you, because the stories just get construed and we want to know the truth ultimately. And it's just for patient safety.
Got it. That makes sense. What is a nurse anesthetist? How do you guys work together?
Yeah. So a nurse anesthetist is a nurse by training. So they typically have a nursing education. So they go to undergrad, get their bachelor of nursing, which is usually 4 years. And then they work Typically, they're ICU nurses, sometimes ER nurses, and they've been working for, I believe the minimum requirement is 2 years. They have to be working in either ICU or ER. And then from there, they can apply to take a nurse anesthetist training program, which used to be a master's degree, but I believe most of them now are PhD degrees. And so I don't know for sure, but I think it's 2 years that they have to do schooling in just specialized anesthesia training. And then if it's a PhD, obviously they have to do some kind of like a study or a thesis or something. And so they're nurse by trade, but they have specialized training in anesthesia. And so they can deliver anesthesia, but the states are the ones who kind of make the laws as to whether or not they can practice independently.
Mm.
And so every state is different. And so we work in conjunction with the nurses. Um, Ultimately, in Maryland, most of the time the nurses are working under us in hospitals. Sometimes you might encounter a nurse anesthetist maybe in cosmetic surgery where they're practicing independently. But most of the time, for higher acuity surgeries, surgery centers, and hospitals, they're working under an MD.
Got it. Going back to before the surgery even happens, what is your role in determining if a patient is safe to be administered anesthesia?
So that's a big question. But first one is, did you eat anything? Because that's the easiest one. If you had something to eat, well, not safe, right? For the reasons I mentioned before. Most of it boils down to whether or not you have comorbidities. So if you have other health problems, if you have high blood pressure, we typically tell patients not to take certain blood pressure medicines the morning of surgery. If their blood pressure is too high, then then it cannot be safe for surgery.
With blood pressure, say you have white coat syndrome and your blood pressure is spiked because you're freaking out and you're nervous, you're having surgery, or you're in pain and your blood pressure is high. How do you discern actual high blood pressure versus those other factors?
Yep, good question. So everybody has white coat syndrome when they come in for surgery because it's really anxiety provoking. So we understand that. And a little elevation in blood pressure is fine. 120 over 80 is normal. If you're 150 over 85, we're probably not going to say anything. If you're 200 over 100, we're concerned. If you're like 220 over 110, we're going to cancel you. And usually what I do for my patients is if I know it's like anxiety related, I just try to I try to answer any questions that might calm their anxiety or just talk to them, give them a little time too. Like as they settle in, they meet people, they know I'm their anesthesiologist, I'm going to care for them. Then they get a little more comfortable, and then their blood pressure will naturally come down on its own. So a lot of the times, with even just like some breathing techniques, like you can relax your own blood pressure and you don't need to be medicated. The problem is if you have high blood pressure and it's not treated, and then you come in for surgery, most of our medicines are going to drop your blood pressure. And so you're used to walking around with a high blood pressure, and then we're going to make it low pretty quickly. And so you're at high risk for stroke.
Mm.
So, and also if your blood pressure is just super high and it continues to be really high, then you could also stroke. So, stroke is our biggest concern with blood pressure. Then, if you're asthmatic and right now it's allergy season and you come in and you're wheezing, well, it's not safe for me to give you anesthesia right now because you're going to have a asthmatic attack. You're going to have a bronchospasm. I'm probably not going to be able to deliver oxygen to your lungs and you risk dying ultimately. If you have heart failure and you come in with a heart failure exacerbation, if you have COPD and you come in with a COPD exacerbation, like any of these things, I'm going to cancel because it's just not safe, especially if it's an elective surgery. So if you're coming in to get an ACL repaired, then I'm going to cancel. But if you have a fractured hip that needs to be fixed, well, then we have to weigh the risk and benefit of how long should we wait before your other medical problems are better or improved before we do the surgery so that it doesn't impede healing and that kind of stuff.
What actually happens to our vitals when we are when you're monitoring what is normal to happen? And when do the red flags or orange flags start to wave?
So ultimately, there's five vital signs that we monitor that are required by law for us to monitor. So we always have to have a pulse ox. So we monitor your oxygen level. We always have to have a blood pressure. Now, whether that's non-invasive blood pressure, which is like the blood pressure cuff, or if you're really sick, then we'll put an arterial line in. We have to have temperature. We have to have heart. We have to have an EKG. So I need to make sure that you're not having a heart attack under anesthesia. And then I need to monitor your end tidal carbon dioxide levels. So those five things for anybody getting like moderate sedation, deep sedation, general anesthesia, those are required. So each one of those has a normal value, and that normal value will change depending on your comorbidities. But ultimately, like I was saying earlier, our medicines will drop your blood pressure. That's a given. Most of the medicines that we give you for anesthesia will cause some form of vasodilation and hypotension. So we're always kind of watching for that. And because we know it's going to happen, sometimes we'll just give you the medicine slower. Sometimes we'll treat it. Sometimes there's if after we induce with anesthesia, meaning we put you to sleep originally the first time, the slug of propofol, they say, then if you're going to get an airway, if you're going under general anesthesia, that airway placement can be very stimulating. So that in turn is going to make your blood pressure high, which might offset the low blood pressure of the medicines we just gave you. So there's so many things that we're watching for, but those are the five main vital signs that we're constantly monitoring and watching. And any deviation from normal, we should be actively forming a differential diagnosis in our mind and trying to figure out what's going on and how we can fix it.
I know patients are often fearful that they're going to wake up in the middle of surgery. How can you not let that happen? Or why does that not actually happen? Or does it happen?
Yeah. So, well, you watch movies, right? Yeah. So it can happen. It's
How
very
common is
rare.
it to happen? Yeah,
It's
okay.
very rare. I can't remember the exact statistic, but I want to say it's something like 1 in 100,000 or like 1 in 500,000. It's very rare. And it's more common to wake up under sedation. So if you're going to have, say, a colonoscopy, we're going to give you some sedation. Okay, they're not cutting you. It's uncomfortable, but it's not painful. They're just kind of monitoring for colon cancer screening. So if you wake up and you might remember something, most people don't even remember anything when they wake up in a colonoscopy. But you're not under general anesthesia, meaning you're not like deep asleep. There's kind of levels of anesthesia, right? Now, if you're under general anesthesia, you risk waking up. Ultimately, I guess if you let's backtrack. So, most general anesthesia, if you require a breathing tube for surgery, so let's say, for example, spine surgery, that's kind of a given, especially if you have to go prone. We're going to put in an endotracheal tube because we need to secure your airway. You're going to be laying on your stomach. We need to be able to have a secure airway that's going to, give you oxygen and anesthesia gases. So you're going to get general anesthesia. You're going to go deep to sleep. You're going to get an endotracheal tube. We're going to intubate you and we're going to put you prone. For those patients, how we kind of make sure they don't wake up during surgery, we monitor vital signs. If you're starting to wake up, then you're going to get anxious. Your blood pressure is going to go up. Your heart rate's going to go up, those kinds of things. We have some other monitors. We have what's called like a BIS monitor, kind of goes on your forehead, or like an EEG monitor. They monitor brain waves. So they kind of monitor like the depth of anesthesia, the brain waves, whether or not, you're sleeping, you're awake, and that has a little spectrum as well. So if you're under general anesthesia, then there's a certain number range that you want to be within. So that's sort of an extra monitor that we have that would allow us to see whether or not you were getting light with anesthesia. But I think like the scary thing would be patients waking up, not necessarily waking up and remembering, but waking up but not being able to say anything or say like, hey, I'm awake. And that situation is very scary. even more rare, but that would be in a situation where you're paralyzed, but you're not anesthetized. That's in theory, it's happened before. I haven't read stories, I've seen movies. Scary, you don't want to be there. But at the same time, I guess in theory is possible because we do have to paralyze patients for many different surgeries. We need your muscles to be relaxed if they're putting a hip in. If you're doing a spine and they're working on the spinal cord, we don't want you moving during surgery. So we have to paralyze you. So when we paralyze you, obviously you can't talk, you can't move. And so if your anesthesia were to wear off or something were to happen, then that would be that scary situation. But it's super rare because we have so many monitors that would check that. And also, there's always somebody there, anesthesia wise, whether it's a nurse or a doctor monitoring you. So thank God, it's very rare.
Tell us a little bit about general anesthesia. You told us about sedation. Where does local anesthesia, epidurals, nerve blocks, where do those come into play?
So local anesthesia would be what that's essentially like lidocaine and its cousins. Um, and that's going to numb up the local area around wherever it's being injected. So if you are having a mole removed on your cheek, then they're probably going to give you some lidocaine or whatever local anesthetic around that area so they can remove it. And it's only going to work in that area. Regional anesthesia is kind of using those similar medications, but we're targeting nerves and larger nerves. So a larger part of your body, a regional part of your body is going to be anesthetized. So for example, let's do an ACL. So they're going to make an incision over your knee. I want to numb up the area where they're going to make incision. So typically I want to target the femoral distribution. So I would target your femoral nerve to numb up the distribution of your femoral nerve. Now, if you're having a knee replacement, typically the surgeon is going to want you participating in physical therapy right after surgery. So I don't want to knock out your motor components. I only want to kind of target your sensory components. So we have to change up our approach a little bit so that I don't knock out your motor nerves. But there's different ways we can do that. And that would be like regional anesthesia. So we can do upper extremity regional anesthesia in the brachial plexus, which would target like a shoulder. It could do an elbow. It could do a hand. And then I can do lower extremities, which, would be like thigh, knee, ankle, foot. And then epidural and spinal anesthesia. So that's where I'm injecting the local anesthetic, but I'm injecting it in the epidural space or in the intrathecal space. So if you're coming in to have a C-section, I'm most likely going to put in a spinal, which is going to go in your intrathecal space, and you're going to go numb from about your chest down to your toes. And so that's called neuraxial anesthesia because it targets your spinal cord, essentially. The epidural is a little different. It goes in the epidural space. Typically, if you were going to have a baby or if you were undergoing like a huge belly surgery, a chest surgery, something like that, we can also target nerves in the chest and abdomen with epidural anesthesia. And so we put in a catheter so we can run an infusion that will hopefully keep you, a little anesthetized, and mostly it's for pain control after surgery or during labor.
Can you quickly tell us about getting nerve block?
So typically what we're going to do is, we'll sedate you a little bit. We give you a little anti-anxiety medication because a lot of people can be, really anxious about that because it is a needle. And so we use the ultrasound. That's going to help us identify, your tissues, your arteries, your veins, and your nerves. We want to target your nerves. We don't want to inject this into a blood vessel. It's not going to work there. It's probably just going to make you sick. And we want to make sure that, you're getting the medicine where you need it. So typically we give you a little anti-anxiety medication. We'll do a timeout, make sure that we're doing the block on the correct side where you're having the surgery because we don't want to do the wrong side. And then we will take the ultrasound and identify our anatomy. And then we inject the numbing medicine underneath ultrasound guidance. Sometimes we can also put in catheters if you're going to need longer term pain control. But with the medications that we have, usually you can get anywhere from 12 to 24 hours, sometimes up to 72 hours with a specific medication if we inject that. So the catheters are more for specialized procedures.
Very
Yeah.
cool. I'm going to backtrack a little bit, going back to the prep of the patient, like before they
Yep.
even enter the OR. Why do they take the neck measurements? What is that for?
So that's basically we're screening for obstructive sleep apnea.
Mm,
So patients who are obese, patients who have large necks, patients who snore, they're at higher risk for sleep apnea. And if you have sleep apnea, then one, you're at higher risk for apnea after surgery, but also because you're getting pain medication. So with narcotics specifically, it's going to slow down your breathing. It could increase your risk of apnea, and then that could potentially lead to hypoxia, which then, you know, if it got too bad, you could end up, having a heart attack. We want to avoid all of that. So we screen patients for sleep. They'll probably ask you if you snore too while the nurse is taking your neck measurement. She's probably saying, do you snore? Do you snore really loudly? Can people hear you through doors? These are just kind of like screening questions.
got it. And what about smoking? How does smoking affect anesthesia, or does it?
So smoking, yeah, many ways. So one, smokers have more irritability in their airways. So kind of just like asthmatics. Also, they have more mucus. They tend to produce more saliva. They have poor wound healing. They can require more anesthesia as well. Just because I think the nicotine essentially ramps up your sympathetic nervous system, and so therefore you just can require a little bit more anesthesia if you're a smoker. So that's why obviously we're going to always recommend you to quit smoking and stop smoking. And I recommend to all my patients, doesn't matter what they're smoking, marijuana, cigarettes, or even if they're just vaping, like nothing you inhale in your lungs is good, including pollen, right? As we can see in the pollen season right now, like people are having asthma and hay fever, and it's not good. And various chemicals can also kind of cause that too. So people who work in specific industries who might be inhaling chemicals, even if they're not smoking, they can still have really irritable airways.
You're talking about the blood pressure and how the meds that you give can tank your blood pressure. What do you do for the patient that starts with a low blood pressure and they need surgery?
So typically we will give you lots of fluids. Um, and because we want to make sure that you're well hydrated, because if you're dehydrated, then you tend to get low blood pressure more easy. Um, and we give vasopressors a lot of the time. So we give medicines that will kind of squeeze your blood vessels and bring your blood pressure up. And those help quite a bit. And then, like I was saying earlier, we can also just the slower we give you anesthesia, the less it kind of drops your blood pressure. So if you have normally low blood pressure, then we might just go slower and have you count back from 100, and you might get to 80 instead of 95.
Got it. And how long does it take for someone to be officially under?
Well, it depends which agent you use. We have
Okay.
a few different, anesthetics that we can use, the most common being propofol, probably the most famous too. And so propofol works very quickly. So after you get propofol, I mean, people can't even count to 95. So it works very quickly. But it depends on how strong your heart is too. So people with heart failure typically takes them a little longer to fall asleep because their heart isn't functioning as well. So they're not perfusing their body as quickly as say, an athlete would be. So they typically go to sleep slower.
I've had surgery at a few different places, and depending on where I have surgery is depending on if I get sick or not after I wake up. Is there a different cocktail that different surgery places use, and how would that affect that?
It's provider dependent, right? So it's the agents that you're familiar with. We all know that anesthesia can cause postoperative nausea, vomiting. That's a given. And it also depends what agents you use, because there's different agents that we have that can, provoke postoperative nausea, vomiting. So Typically, we use Zofran and Decadron, which are like antiemetics to kind of help you when you're waking up. Sometimes we'll do the patch, the scopolamine patch behind your ear. It's like a motion sickness patch that can kind of help you when you're waking up.
Don't touch that to your eye.
Yeah, exactly. Unless you want to think you're having a stroke.
Live and you learn.
Yeah. But it just depends. If we know that you have post-op nausea vomiting, sometimes I'll run what's called TIVA, which is total intravenous anesthesia. So I don't actually give you any inhaled anesthetics, because the inhaled anesthetics are directly related to higher incidence of postoperative nausea vomiting. Sometimes we can run like a low dose propofol infusion that also has antiemetic properties, so can help, then we risk stratify. So most places should be risk stratifying. So if you're young, if you're female, if you're a non-smoker, if you have a history of postoperative nausea vomiting, and or depending on the type of procedure you're having done, those are all high risks to have postoperative nausea vomiting. So if you have, one or two risk factors, if you're an 85-year-old male getting your hip replaced, then you're not likely to have postoperative nausea vomiting. So we'll probably just use one, maybe two agents to help you out, because most people are on an empty stomach. They're getting pain medicine. You're not going to be feeling good waking up anyway. But if you're high risk, so if you're a 20-year-old non-smoking female who's having laparoscopic surgery to get her gallbladder out, well, you're going to need everything, because you are going to wake up feeling sick and probably vomiting because you have all the risk factors.
That makes sense. And again, I speak from a lot of experience, unfortunately. So I've seen a lot of how different things are done. But it seems like different places also have, like you said, this scopolamine patch, but also this bracelet that they put on, and then aromatherapy. Have you seen these different tools to try to reduce post-op nausea?
Yes, I think we have lavender sticks that you can
Mm.
inhale at our hospital. But yes, I have seen those. So ultimately smell is kind of unfiltered. So when you smell something, it goes directly to your brain. There's like a direct connection. It's one of your most primitive senses. And so I think the essential oils, some of them, when you inhale them or you smell them, they sort of have an anti-nausea, antiemetic effect. And that's probably because the vomiting center is in your brainstem. So when you're going to be sick, it's not actually from your stomach, it's from your brain. So I think like some of those essential oils just kind of have like a calming, relaxing effect to them. They've been shown to like relax muscles. So not only is it going to go straight to your brain and be like, oh, happy, neurotransmitters are being released, but also maybe it might like sort of decrease like your stomach and the muscle contraction in your stomach that might be happening from the nausea and the vomiting. So that's what I could digest out of what I read, at least yesterday.
I
When I was
appreciate
looking
I
into,
appreciate you looking into it.
yeah.
So we talked about before surgery, the patient's going under, what you're monitoring while they're under. Now we're awake. I've experienced like very different stories from patients. So when I have kids who've had surgery, they wake up and their parents are showing me these videos of their kids, just no filter. They're hilarious. Versus like an adult, they seem to have less of that fun, side effect post-op. Is there anything to that?
I don't know that there's anything to it. In my experience, I think that kids kids are sort of like, I guess you would say virgins when you think about it, right? Like they haven't really been consuming alcohol. They hopefully aren't doing drugs. So when we give them these medications, they're kind of like just disinhibited, and they're just like, oh, okay. And so the thoughts, I think, just flow freely. And obviously they have no sort of anxiety about voicing that because we've given them medication. So I think that's probably part of it. The other thing too, it kind of just boils down to like your metabolism, and also, if you have any comorbidities, whether you feel sick when you wake up. But I know some people, they wake up and they're like violent. Some people wake up and they're really violent. Men and women doesn't matter, but just certain people are violent. Certain people will wake up and they're just crying. They're very emotional, and they're like, I don't know why I'm crying, and I'm like, it's okay. It's just kind of a side effect. And so I think people maybe just inherently have this, their personality, right? And I always tell patients that when you go to sleep under anesthesia, I ask them what they're going to dream about. And I tell them to pick something nice and dream about it as they're going off to sleep. And then typically when they wake up, they sort of wake up the way that they fell asleep. So if they're trying to fight the anesthesia and they're like, no, like I'm going to win, I'm going to beat this anesthesia, they're the ones who are going to wake up like kicking you and punching you. And if they go to sleep and they're like dreaming about Santorini and being on the beach and the warm sun or wherever their happy place is, then they're usually going to be like calm and like super sweet when they wake up. So I don't know. I can't explain it, but that's just what I've witnessed.
The brain is an amazing thing.
And there's so much we don't know about it.
Hmm.
Yeah.
How long does anesthesia hang around in our bodies?
So it depends on the medications that you've received. So we use many different medications, and it depends on how quickly you can metabolize those medications and how quickly you can eliminate them from your body. So it depends on your liver function, your kidney function, your lung function. So it's variable for everybody. But I would say most of the drugs are out of your system within a few hours, but some hang around for up to 24 hours. So that's why we kind of recommend having somebody drive you home and not operating a motor vehicle for a day, just because there could still be residual effects. So if you have any liver disease or kidney disease, then the effects of anesthesia are going to linger a little bit longer. Like I said earlier, if you have any heart failure or any problems with your heart, well, then you're not pumping blood as efficiently. So, it's going to be slowed that way too. Usually, if you're young and healthy and don't have any medical problems, then you're going to clear these medicines a lot faster. So you might feel great after 4 to 6 hours as opposed to 12 to 24 in an older, more sick patient.
Is there anything we can do as patients or to help our patients make that go faster? Like, is hydrating good, not good? Does it depend on your symptoms, how you're feeling?
Yeah, hydrating's good. Hydration's always good for everything. So yes, if you're hydrated, then your kidneys are going to work better. You're going to filter out stuff faster. You're going to pee out all the metabolites, and you're going to get it out of your system. So that's always good. I mean, there's not really anything to do. Obviously, if you're having symptoms, like if you're having nausea, if you're having vomiting, then we don't recommend eating anything. Just taking some medication. Um, and that's why, like, if we know that you're going to have problems with nausea, vomiting afterwards, then typically we'll use that patch because that can stay on for up to 3 days. So, especially for people having outpatient surgery going home the same day, the car ride can be kind of not fun. And so, I usually tell patients to leave it on until they at least get home and get settled at home and see how they're feeling. But yeah, I think that would be about it.
This has been extremely helpful. I thought it'd be cool to have a conversation with you because a lot of physical therapists and whoever listens to this may not have had surgery themselves. So to understand what our patients go through, I think is really important. Is there anything we haven't covered that you want to tell us about with regards to your field?
For people who've never had surgery, yeah, I think just like understanding the anxiety around not only having surgery and anesthesia, but a lot of patients have anxiety around the recovery. And so, like you were saying earlier, I do a lot of ortho surgeries. A lot of my patients are young athletes. They're like, how long is this going to take? How long am I going to be at a sports? When can I, get back into it? That's really hard for me to say because I'm only taking care of you in the acute phase of your surgery and then for an hour post-operatively. So I don't really have much to do with that, but I usually tell them, to stay in close contact with their surgeon who's going to make recommendations for them. But you guys as physical therapists are going to support them through that journey. And I think that's like important, even almost more important because that's a lot of their anxiety stems around their recovery because they've made it through surgery, but now they're like, now what? Am I going to get back to where I was? How do I manage with, my new ACL or my, this pin in my foot or whatever? And that's where you guys come in.
I would like to say surgery is the easy part. You get to go to sleep and then
Yeah.
you wake up and the work starts.
Yes, exactly. It's a long journey.
It is.
Yeah.
Cool. We like to end our episodes. I like to know your favorite quote. What moves you, drives you, inspires you? It doesn't have to be work related, but what is your favorite quote?
I don't even know. I tried to look this up. I don't really have favorite quotes. Um,
What's a motto you live
uh,
by?
that's funny. So I guess a motto that I live by would be that there's something to be learned from everybody. So regardless of who you come in contact with, you can always learn something from them. So I just remember in like medical school and training, there's always the dichotomy, because we were always in the era where the doctor is like the top, and they know everything, and then, then you have nurses, and then you have like techs, and then you have EVS, like environmental service staff. And so, but it's like, that's not necessarily true because my tech helps me all the time. And I'm constantly like, where can I find this? Where can I find that? And she knows, she's like, oh, Dr. Harris, this might help you. And I'm like, oh, thank you. And so, like, I feel like you have to sort of take that approach to life, because I believe that humility is the best character. And so you always have something to learn from everybody, regardless of the initials behind their name.
Love it. Usually I ask where people can find you, but I don't think
Uh,
people want to find you.
so yeah, if you want to come visit me, I will. I spend most of my time at Harbor Hospital, MedStar Harbor Hospital in South Baltimore. I do the odd time frequent Union Memorial or Good Samaritan Hospital, but that's maybe once a year. Um, And then, if you don't want anesthesia, but you have a chronic medical problem and needs functional medicine, I'm currently getting certified in functional medicine. And that's more sort of root cause medicine and for chronic diseases and that kind of stuff. So it's very different from my anesthesia journey, but something that I'm really passionate about.
That's really cool.
Yeah,
Sweet. Dr. Harris, thank you so much for taking some time to educate us on everything about anesthesia. I really appreciate it.
no problem. Thanks for having me.
Thanks for listening to the Let's Get Physical Therapy podcast. Be sure to subscribe to our podcast and follow us on Instagram at MedStar Health PT. If you've enjoyed today's episode, please give us a 5-star rating and leave a review so we can reach more listeners just like you. As always, we appreciate your time and hope you join us for our next episode.